year, and it has been continued by SIBIN very well till last time. So this term's first meeting, we'll have the shoulder theme, where we have international faculty from the National University Hospital, Singapore. He's now actually the in charge of the sports division there and the shoulder and elbow team there. So welcome, Doctor, to this meeting. And also I would like to welcome both the case presenters. So we'll start with the case presenters first and handing over the proceedings to SIBIN. Also welcoming Harish Chandran, who is a very busy practitioner at Trivandrum, to moderate this session. SIBIN can take over.
Thank you, John, sir. So welcome you all once again to the webinar series from Arthroscopic Association of Kerala, commonly known as the Wisdom Trade series, where we share one important topic that is presented by a national and international faculty, and that is followed by 2 case presentations. So each has a good time. We have an ample time for discussion, and it's good take home for each talk. So in today's session, as highlighted by John sir, is based on shoulder surgery. So we have an important talk on massive rotator cuff tears. What are the options from Dr. Wang Ming from Singapore, followed by 2 case presentations. And all the sessions will be moderated by Dr. Harish. He's from Trivandrum. So without much ado, I think I hand over to Harish to start the session.
Hi, welcome you. Great to be here. Thanks to Dr. John and Dr. Spin for the invite. First speaker is Dr. Thomas Mathew from Luth Hospital, Kochi. Not all fractures of proximal humerus are the same. Yeah, I think proximal humerus is a very intriguing joint, and fractures related to that require real sheer skill, basically, when you try to fix it. So I think probably Dr. Thomas will put a lot of insight onto that. Over to you, Dr. Thomas.
Recording in progress.
Good evening, everyone. There is this echo. Am I audible?
Yeah, can hear.
All of them can mute. Everybody can mute their audio, I think. So it will be loud and clear to all. Dr. Wang Ming, we can continue your talk after this. Is that fine? Dr. Ming Wang, hello.
If he's ready, we can go ahead with his talk. Otherwise, we'll have the case presentation.
Dr. Wang Ming, is that fine that we go with the case presentation? After that, we'll have your talk. Is that fine?
Sir, can you unmute?
You are unmuted. Please unmute.
Go ahead.
Yeah.
Go ahead with your case presentation. I can present after your case presentation.
That's fine. Thank you. Thank you.
So we'll have one case presentation, then we'll have the faculty talk, then we'll have the second one.
Okay, Dr. Thomas.
Good evening, everyone. Before beginning, I would like to express my sincere thanks to my mentor and AASK President, Dr. John T. John sir, AASK Secretary, Dr. SIBIN sir, Dr. Harish sir, and other AASK office bearers for giving me this opportunity to present a case here. Thank you. The proximal humerus fractures represent about 5 to 6% of all fractures in adults, and it is the third most common fracture in the elderly after the hip fractures and distal radius fractures. Isolated greater tuberosity fractures comprise about 1 to 14% of all proximal humerus fractures, and among these, 5 to 57% of GT fractures are associated with anterior glenohumeral dislocations. Studies have shown that residual shoulder instability after fixation of the fracture is uncommon. And some earlier studies had even reported that the greater tuberosity fracture dislocation has a lesser incidence of redislocation than an isolated shoulder dislocation. I'm here presenting a rare case of recurrent anterior shoulder instability after a greater tuberosity fracture dislocation. My patient was a 46-year-old male. He was an alcoholic with chronic liver disease. He came to our emergency with a history of fall after a seizure. And this was his initial X-ray. There was greater tuberosity fracture dislocation, and the greater tuberosity fragment was a lot displaced. It was promptly reduced in the emergency department. And this is the X-ray after reduction. Still, you can see that the greater tuberosity fragment is a little displaced. So in such a case, would you take a CT? There was a study among 164 surgeons, and it showed that the addition of a CT did not result in a difference in recommendation for surgery compared to plain radiographs alone. And they concluded that it made no difference in the management choice. Anyway, we did not take a CT, and we planned for an open reduction and internal fixation, and did the same after 1 week of the initial injury. These are the immediate post-operative X-rays. The fracture was well reduced, and intraoperatively the shoulder was stable. But after 3 weeks, the patient presented again with shoulder dislocation. It was reduced closely, but a few days later, he presented again with another spontaneous dislocation. So there was obviously anterior shoulder instability, and we had to do something about it. Taking a CT to assess the glenoid bone loss and an MRI to assess the associated capsulolabral injuries was ideal in such situations, but this was a difficult patient who was reluctant to undergo a second surgery, and the second surgery had to be an open one since he underwent an open procedure recently. Also, this had to be a definitive one since he was a reluctant patient. So we planned for an open lethargy and proceeded to do the same without taking a CT or MRI. This was the post-op X-ray after the lethargy procedure, and this X-ray was at 3 months of follow-up. This video was taken on the last follow-up 1 month back, and he had full abduction and forward flexion. So that was my case. I will add a few more things about greater tuberosity fracture dislocations. There are several classification systems of proximal humerus fractures. The most widely accepted NEER classification has a single subgroup of two-part fracture dislocation included in group 6. The much more complex AO-OTA classification does not consider fracture dislocations, and there is a classification system, one morphological classification system for isolated greater tuberosity fractures proposed by Much and others, but it also does not include fracture dislocations. So very recently in 2022, Forbes Ganok-Roach proposed a classification system for greater tuberosity fracture dislocations. They classified these fractures into 3 types. The type 1 included a small avulsion fracture of the greater tuberosity along with the dislocation. The type 2 fractures included the greater tuberosity fractures without articular head involvement, and the type 3 fractures were greater tuberosity fractures with articular head involvement. And among these fractures, they reported that type 3 fractures had a higher chance of fracture displacement after reduction and needed subsequent surgeries. During evaluation, a detailed neurological examination is imperative before and after reduction to look for any neurological deficit. Among greater tuberosity fracture dislocations, about 5 to 34% of the cases have associated neurological deficits, mainly the axillary nerve. Vascular injuries are very rare, but there are reported cases of axillary artery injuries in greater tuberosity fracture dislocations. While taking X-rays, the AP view in external rotation is the best view to assess superior and inferior displacement. And an axillary lateral view is the best view for anterior posterior displacement of the greater tuberosity fragment. The role of a CT scan is still questionable, but one good indication to obtain a CT before reduction is in an elderly osteoporotic female with a big greater tuberosity fragment to look for an occult humeral neck fracture, because such a fracture, if present, can result in iatrogenic neck fractures while reduction is attempted. So that is an indication for a CT. And regarding reduction, in young individuals under 50 years of age, a single attempt of closed reduction under moderate sedation is recommended. And if that fails, or in the case of an elderly individuals above 50 years of age, it is better to attempt closed reduction under general anesthesia with adequate muscle relaxation to avoid iatrogenic fractures. If reduction is successful, minimally displaced and undisplaced fractures can be managed conservatively with close follow-up, because up to 51% of greater tuberosity fractures can have secondary displacement on follow-up. Then there is an irreducible greater tuberosity fracture dislocation, or when there is an iatrogenic fracture while attempted reduction, or if there is a more than 5 mm displacement in any plane after reduction, open reduction and fixation is recommended at the earliest to avoid complications like avascular necrosis. Regarding surgical treatment, there are many techniques described: open, mini-open, or arthroscopic, using suture fixations, suture anchors, and cancellous screws. But in the case of a large split fracture, like in our case, the best construct is a proximal humerus locking plate with non-absorbable sutures passed through the rotator cuff tendons and tied to the suture holes of the plate. This is the most robust construct for a big greater tuberosity fragment. And regarding rehabilitation, it is pretty standard. We start passive motion from day one. Active motion is started at 6 weeks, and strengthening exercises are started at 12 weeks. An MRI is indicated if there is pain, decreased range of movements, weakness, or instability after 3 months of the initial injury, to look for any associated soft tissue injuries. In 2024, there was a review of all the studies, including greater tuberosity fracture dislocations. And this study, this review, concluded that it is better not to address the capsulolabral injuries in the acute stage, since the concomitant repair of fracture and the capsulolabral complex increases the risk of stiffness significantly, making management and rehabilitation difficult. They concluded that residual shoulder instability after fixation of the fracture is uncommon, and it is an easier problem to address than the stiffness when the repair is concomitantly done. Among studies of greater tuberosity fracture dislocations that did not repair the Bangkok lesion, only one study reported a case of recurrent instability that was successfully treated non-operatively. So this shows that recurrent dislocation after a greater tuberosity fracture dislocation is fairly uncommon. But even if that happens, the management depends upon the amount of glenoid bone loss, like in the case of a recurrent anterior shoulder instability. Options include arthroscopic or open Bangkok repair, or if there is significant bone loss, a lethargy, or there is greater bone loss, an iliacrus bone block procedure. So to conclude, greater tuberosity fracture dislocation should be considered a separate entity than other proximal humerus fractures. In these fractures, an iatrogenic humeral neck fracture can occur during attempted reduction. Non-displaced and minimally displaced fractures can be managed conservatively with close follow-up. More than 5 millimeters of displacement of the fragment in any direction should be fixed. And even if rarely, recurrent instability can happen, and subsequent surgery will be needed to address the glenoid and labral injuries in such cases? Thank you. Thank
Yeah,
you.
Dr. Thomas, that was a good insight on your talk. I think the shortage of time, we'll probably take questions towards the end, and we'll get going with Dr. Ming's talk. Is that okay, SIBIN?
Yeah, I think that will be fine.
Yeah.
Dr.
All
Ming.
right, I will share my slides. So I use my another device to get a video because somehow it just doesn't work. All right, so I'm going to talk about the massive rotator cuff tear. There's some controversies, and you know, going to talk about what are the solutions. Can you hear me and see the slides? Sorry.
Yeah.
Okay. All right.
Yeah. Please.
So I'm going to talk about what are current solutions and advancement. No conflict of interest. So massive irreparable rotator cuff tear, there are a lot of controversies, and even the definition, what is massive? How to define a massive rotator cuff tear? And how to define an irreparable rotator cuff tear? A lot of people, some surgeon may even say there's no cuff tear is irreparable. It just depends on the skills, but I doubt that. So the definition starts with you know, a lot of debate. But in large, that we will define a massive rotator cuff tear. In most of the papers, we will tear size more than 5 centimeters. Number of tendons involvement is more than 2. And the RC retraction usually is PAT 3, which is at the glenoid ring level. And the fatty infiltration, Gotalians, more than 3 to 4. Because of the controversy, so the American Shoulder and Elbow Society conducted this sort of survey from 20 experts in US. It's called a Delphi method. So they did 4 rounds of survey from 20 experienced shoulder surgeons. The first rounds, the core characteristics of massive rotator cuff tear involves a tear size, number of tendons torn, and degree of a medial retraction, just as what we talked about. The second round, they determined that the tear size should be measured as a relative value rather than an absolute value due to the patient's size difference. The third round, the retraction of the tendon to the glenoid ring and or a tear with more than 67% of greater tuberosity exposure. This is a 69% approval. That means you either have a retraction of tendon at a PAT 3 or the exposure of the greater tuberosity at more than 67%. So it's a relative value. The fourth round is about the similar, just more detailed degree of retraction, how to measure them. It's either in a coronal plane or axial plane, and how to calculate the greater tuberosity exposure that should be in the sagittal plane. So this is a Delphi method. It's quite complicated, but I will still use the previous paper as my main measure to say, you know, what is a massive rotator cuff tear. And the next question is, what is irreparable? A tendon is irreparable if the tendon stump cannot be advanced to the footprint and lateral to the articular margin with a tension-free repair. This is one of the definitions from the literature. However, the term tension-free is somewhat subjective. A lot, you know, how much is tension-free? Because different people may have different, you know, definition on that. Can you pull it to the native footprint or a medialized footprint? And some surgeon even went much further on that. They developed this kind of very complex formula and a scoring system, which I don't think any of the clinicians that will be willing to use this to predict the repairability before the surgery. The next concept is a pseudo-paralysis, or you can call it pseudo-paresis because they are not completely paralyzed. So the pseudo-paralysis is a clinical finding that describes the inability to forward elevate arm more than 90 degrees with better passive motion and without another neurological explanation because it's just purely due to rotator cuff. There's no nerve damage or there's no radiculopathy. So there is a very nice paper from Jill Walsh about 10 years ago. So how to tell, which type of rotator cuff tear tends to produce a pseudoparalysis. So they define the 5 types of rotator cuff. You can see on the right side of the figure that there are 5 types. So you can see the from right side is the supraspinatus, the superior and inferior. If let me just try to use the screen pointer option. So superior subscapularis, inferior subscapularis, supraspinatus, infraspinatus, and teres minor. So they found that the type B, C, and E, these 3 types, actually produce the largest percentage of pseudoparalysis, and especially type B. And you can notice that type B actually is a complete subscapularis tear and a supraspinatus tear. That actually will cause the humeral head to anterior superior escape. That is one of the reasons that this causes pseudoparalysis, because the humerus head is decentered. I have this patient, let me see, play the video. So you can see actually, look at his head. On the side view, you can see he has anterior superior escape. The humeral head is anterior superiorly positioned and it's decentered from the glenoid. And he cannot raise up his arm, but if he actually popped his head back in the glenoid, centered in the glenoid, he can actually raise up using his deltoid muscle. So the type B actually causes anterior superior escape. So that will cause the decenter the humeral head and cause pseudoparalysis. Okay, so next is actually rotator cuff retraction. This is a very old concept. Didiopet published in 1990s. We all know that 3 types: minimal retraction, retraction to the humeral head, and glenoid retraction to the glenoid ring. And a Guttalian classification, I'm not going to spend too much time on that. I think someone is actually drawing on the screen with the yellow lines, so maybe you can erase that. So the Guttalian 1 and 2 is look like, it's lean muscle, and Guttalian 4 or 5 is lots of fatty infiltration. And Hamada classification, it's actually one of the classification more actually to describe the cuff tear arthropathy, means the head actually gone up and cause acetabilization of the acromion, and in the end will cause cuff tear arthropathy. So where we are and how is the history and involvement of the treatment options? I mean, in the long time ago, there's a limited option to treat a massive rotator cuff tear. And at this moment, at about after 2020, there are a lot of options available. There are tendon transfer, there are balloons, there are superior capsule reconstruction, tubuloplasty. There are a lot of options. And how do they work? So there's 3 actually rationale of treatment strategy to treat a massive rotator cuff tear. The first concept is to create a smooth subacromial articulation for the humeral head, means that to prevent impingement there. But that doesn't cause you to, that doesn't give you any, mechanical advantage. The second option is reconstruct the capsule or muscular tendinous unit. That will actually help you to decenter the head and use the surrounding muscles to, including the deltoid, mainly the deltoid actually, to move the shoulder. The third one is actually more giving a more mechanical force, which includes tendon transfer and the partial repair of this rotator cuff. So I will go through most of these options and see how their outcome, how is the outcome, and what are the options that we can do for the patients. So partial repair is available option. It's easy to do, doesn't require any special instrument and all that. So that based on the Burkhart's concept of the cable. So it's like a bridge. So if you repair the two ends and leave the center unattached, you still have a good tension and a good pulling force on the humeral head. But the outcome seems to be poor in the long term. There's a good short-term outcome reported, but after 2 years, 50% of the patients was not very happy about this. And next is augmentation. There are a lot of augmentation options, biological, including PRP, stem cells, bone marrow aspirate, growth factors, scaffold. There are a lot of variable evidence available. There are a lot of industrial-driven factors playing inside. I will go through quite a few options here. And this actually it's an old and new concept. Biceps augment, smash biceps autograft. So actually, this described many years ago in 1971 that in an open repair of the rotator cuff to reinforce this. But of course, this idea is newly reinvented by John Tokic, and they have actually used this autograft. Once you do a biceps tenotomy, you're taking out a chunk of biceps tendon and you smash it and make it a patch, so you can repair as using as an autograft and biological augment after repair. And the outcome seems to be quite good. They have similar outcomes after compare the repair with or without long biceps tendon augmentation, but the retear rate seems to be much lower compared to the RC repair alone at the 2-year follow-up. Biological augmentation, this idea is from Gus Mazzucca. He was one of my fellowship mentor in shoulder. So he actually used an acellular dermal patch with PRP and a BMAC. It's similar concept. It's allograft, but it's also to augment the repair. But the clinical effect wasn't great for this option. And this collagen patch, there's a lot of, it becomes quite popular nowadays to putting this collagen patch, but it's bovine derived. So if they have religious issues of using the products from cow, so that it will be a contraindication, and the cost is quite high. But from the report in US, the healing rate is pretty good. Of course, there are conflict of interest. Some of conflict of interest are involved because of the industrial factor. And some patients develop some stiffness after using this. SCR, superior capsule reconstruction, popularized by Mihata, was very popular in about 5-6 years ago, and everybody was, very passionate about this. However, Mihata did produce a very good clinical outcome. However, it was not reproduced in US or the rest part of the world because we did not use fasciolata allograft. We used acellular dermal matrix, which is a dead piece of skin. Which is not comparable to the autograft Mihata used. So we could not actually reproduce his results. And it's falling out of favor in the rest of the world. But I think Mihata is still doing quite a lot in his presentation, that he seems to be doing hundreds in the recent few years. So this is the meta-analysis. Again, the fasciolata autograft but not necessarily the dermal allograft. And tendon transfer, it's technically challenging, but this is actually a true, you can produce additional force vector to the shoulder joints for the movement. Traditionally, lat dorsi transfer, it's actually quite popular, and the outcome was pretty good. It reduced the RSA conversion and the progression of the OA. Lower trapezius transfer is something quite new recently, and it's getting popular. It was first described to improve external rotation in traumatic brachial plexus injury, but now it's actually being used for massive rotator cuff tear or irreparable rotator cuff tear. And the lower trapezius has a same force vector as infraspinatus, so it gives quite a good external rotation force. And it produced quite a good result. I learned this from Bassam Al Hassan, who is actually the first one to describe this technique to be used in massive rotator cuff tear. And if you actually have posterior superior tear, he will suggest that you use lower trap. If you have anterior superior, then it will be a lat dorsi transfer. If you have a both, that will be like almost a circumferential, then you can use both combined, both lat dorsi and lower trap transfer. I'm not going to put too much detail, but I'm just briefly going to go through this. The position is usually beach chair with ipsilateral part of shoulder exposed until midline. And you harvest lower trapezius with a transverse incision at the scapular border. Allograft is required, usually it's Achilles tendon. Portal placement similar to the rotator cuff tear. And the allograft passage, usually using a large clamp to tunnel through inferior to the acromion. And the allograft intra-articular attachment is similar to a rotator cuff double row repair. It requires a double row, so to compress the footprint onto the glenoid, onto the greater tuberosity. Sorry. The lower trapezius fixation usually will be a load of suture to crack out. And this is actually the photo to show how the lower trapezius dissected out. And you can see the left, it's actually just inferior and to the scapular spine. And you can separate it and you can flip over and can see the tendinous junction. It's quite a small tendon. It's not a huge piece of muscle. And most surgeons, you will use Achilles tendon allograft, which is long and good enough. And you tunnel through and fix it intra-articularly. And you fix in the shoulder, fixation with the shoulder in a external rotation and abducted position. And rehab, you need to put the patient into an external rotation brace for 6 to 8 weeks. And that time is complete immobilization. The rehab is pretty long for lower trapezius transfer. And balloon, I'm not sure whether it's available in India, but it has been used in Singapore before, and it's actually being pushed in US to use for some patients, usually elderly patients, which can't really go through a very complex surgery. So the balloon is a very easy way out. But again, the outcome is unpredictable. There is an industrial factor playing inside. And the outcome is reported good to short to midterm outcome. But again, the cost and the industrial factor there. RSA, the final reservoir to treat massive rotator cuff tear. Good outcome, but again, it's a bigger surgery. Some patients, for younger patients, may not be good after 60 or 65. And if irreparable and the patient is not high demand, I usually would choose RSA rather than any of the repair options. And there are so many options. We still don't know which is the best way, and the technology is still evolving. And I hope we can find a better solution for this tough situation. That's all my presentation. I hope to take the questions because I need to leave soon. Is that okay?
Yeah, that's perfectly fine, Dr. Ming. Yeah. Dr. Ming, do you have any experience with muscle slides?
You mean the slides, the supraspinatus and infraspinatus?
Yes.
And advance?
Yes, advancement.
Yeah, okay. So that was popular in about 10 years or so ago. They want to slide the muscle and the advancement, but it doesn't seem to be effective. I mean, the outcome doesn't seem to be great. I stopped using this method. Nowadays, you go to conference, rarely people will talk about muscle slides for this to improve the repair.
Okay. SIBIN, any more questions from the crowd?
Yeah, just let me see. Mr. Wing, yeah, hello. What's
Yep.
your take on
Hey.
biceps augmentation? When do you augment?
Biceps augmentation.
Yeah, with in software.
You mean the smash biceps or biceps SCR?
Biceps SCR, I guess.
Yeah, biceps SCR, right?
No, not the biceps SCR. Incorporating
It to
biceps
the repair.
augmentation is augmenting the biceps into your repair rather than
Yeah.
biceps SCR.
Okay.
Especially if it is partial repair, yeah.
what you're trying to say is that use the biceps to pull to the greater to GT and the tenodes there.
Yeah.
And part of your repair.
Yeah.
Yeah. So I mean, a lot of people call it biceps SCR. Yeah, it's a good option. It definitely gives you more biology, and I would do it if the biceps is good quality and quantity, and if the tear is anterior superior, I pull the biceps backwards and the tenodes, and then I can even there's a chance I can do a side to side repair posteriorly.
Yeah.
But for massive rotator cuff tear, sometimes, I mean, most of the time, the biceps is gone. You don't see the biceps anymore.
Yes.
Only for the younger patients.
Sir, I have a question. So you mentioned muscle slide, you feel it. What are the reasons why you think it is not preferred in massive tears? You said 10 years back and now you don't really do it.
The muscle slide.
Yeah,
the muscle slide, you mean?
Yes, sir.
Yeah, it just the outcome. It doesn't. I mean, technically, you can if you don't have other method that you did all the release and you don't have other things to augment it, and that's the only thing you have. You still could do it, but it does not significantly improve how you can repair this. I don't find it's that effective. Even you slide the muscle.
Okay, so thank you.
Dr. Wang, what is your preference between superior capsular reconstruction and lower trap? You talked about both. So for a massive irreparable, I think muscle slide is not indicated for a Gottlieb 4 or 5, which is the indication you said. To call it an irreparable, it has to be Gottlieb 4 and 5, where muscle slide is not an option. But it's a retracted one where the muscle bulk is like Gottlieb 2 or maybe up to 3. You can probably do a muscle slide and do a repair, isn't it?
Yeah, if I mean, even I don't do muscle slides. Most of the time, if the muscle is there, the good tendon quality, usually you can pull back with a good release. Right. You don't necessarily need to slide the muscle. But yeah, so I used to do SCR, but because of the dermal allograft, as I mentioned, that the outcome wasn't good, especially when tear at the tuberosity side. The outcome is worse. If you tear at the glenoid side, it was better because if you tear the glenoid side, the dermal allograft is still at the GT function as a biological tuberoplasty. So I prefer to use, especially for younger patients, use lower trap transfer.
In massive rotator cuff tears, basically with good quality muscle, you tried releasing it and then probably bringing it all the way up to the medial footprint. There's a bit of fraction. So do you always do a suprascapular nerve decompression or that kind of thing?
No, I don't routinely do suprascapular nerve decompression.
Okay.
That's, I think, when you slide more than 2 centimeters is when you have to do the nerve release. Otherwise, you don't require the release, isn't it? And what about subscapularis? When it's irreparable, what is your preference? Would you do a pec major or a teres minor?
Lat dorsi for anterior.
Okay.
Yeah, posterior is a lower trap.
Okay. No pec major for you now.
Was for Sujit for subscapularis, is it?
Yeah, subscap.
Okay.
LD is taking over pec major, which can be done
Isolated subscapularis chronic tear. Do you really require anything to be done?
I don't think it's isolated. He's probably mentioning a combination. I mean, you have a massive rotator cuff tear with it's like a type B, or the one that showed the type B kind of tear.
The anterior superior
If
ones.
isolated subscap, usually they won't have so much problem actually. If your supraspinatus is okay, only isolated subscap, usually they are okay.
Isolated
they don't
subscap, the
usually have any issues.
The comma tissue holds it together. It wouldn't allow it to retract that much.
Yeah.
Dr. Ming, what's your take on this, high rise in use of patches? Is it really of any use, or is it just an industry driven?
It's a good question. Yeah, I feel it's combination. It does work in certain circumstances. You know, if the tendon quality is very poor, you manage to repair, you put it a patch, it could actually get better. But I think it's probably overused. You know, it's an industrial driven thing. A lot of it's the indication and it has been expanded a lot.
Is there any patch which gives structural, stability? Like if there is a gap, you can put this patch over it. You know, when there is a anteriorly or something, if you are not able to bring the cuff, can we add this patch?
Yeah. So you're talking about augmentation in the repair. So I think Ivan Wang does quite a lot of these things. I think there is, MMed, if I'm not wrong, MMed and Artrex has such cuff mend products. There is some biomechanical property.
So if you have an incomplete repair, you can use this patch.
You need to do a connection, means that this patch you have to repair at the tendon end and then connect to the tuberosity. Okay. Or the other way you can use is allograft, either a dermal allograft or tendon allograft.
Okay.
John, I guess I just wanted to put this point forward. I mean, when you have poor quality cuff, though you're able to reach it to the medial row and you're fixing it there, but you have poor quality, then probably maybe a patch could be helpful if you try to reinforce it. But filling a gap, I'm not sure about it.
Yeah, you're filling a gap. Usually you require allograft rather than use this sort of patch.
Usually both goes together. Now, when you have a bad tissue, then it will be, it will be an irreparable cuff along with that. So usually the repairable ones will be nice and juicy.
I thought the initial thing about the patch was just to reinforce the cuff, but I think probably they have extended, like what Dr. Ming said, the company has extended their indications a bit.
Okay. So I don't think the collagen patch, I mean the Regenetin, is used as a bridging augmentation, as a bridging option. No, it's not. It cannot be used as bridging.
There is this Zeros patch, no, that is of the company which sells Neo ligament. They are saying that you can use it to bridge it.
Syros.
Syros.
Yeah, the bridging technique wasn't as popular. The one that talks about most is Ivan Wang from Canada, Nova Scotia. But again, a lot of the evidence from recent evidence is mostly from him, and he does. I think if not wrong, he does allograft. The bridging option is allograft.
I think you can share your video. Is it okay, Dr. Wing?
Sorry, you mentioned about Zurox. So once you fix it in the cuff musculotendinous junction, is there a chance of retear that musculotendinous junction and Zurox patch?
I didn't get the question. Sorry, can someone help me to?
John, I think he was asking about the Syros patch.
No, the Syros patch, they were saying that you can use it when there is a, incomplete repair. So that will add to it. When you have, like sometimes your anterior repair, there will be still a defect. So in those cases, you can patch over both the, you can bridge the gap. But you have to again stitch it over to the tendon. I mean, I've never tried, but that's what they told.
Thank you.
Any experience? I don't know. Sujit is here. No, he can talk more about patches. He has used. I've never used any patch, so I have no idea.
Same here, but I believe the strong indication goes that it's just to reinforce the cuff. It's never to bridge a defect. That's my take on it.
Yeah, patches were started for pasta repairs. No?
Yeah.
So,
SIBIN, your take?
No, I'm also surprised. I think the indication is increasing. I went to that ANA meeting there. Now they are using for the newer companies are coming where they can use it as a filler of the gap. But initially it was started just to augment, as Dr. John told for the bursal tear and the pasta tear and poor quality tissue. Dr. Wing, can you share your video?
Yeah, the video, I think it's here.
You can't see it.
I'm using another device to share my video here. Did you see my videos?
No.
no, we can't see.
Yeah, yes, sir. There are two.
Yeah, I have two locking because the laptop, it just doesn't work. I tried it, but it doesn't work. So I use my tablet to for the video.
I think we can.
All right.
Yeah.
If no more question, and I think if you guys okay, I'm logging off.
Okay, thank you so much, Dr. Ming. It has been a great pleasure to have you here.
Yeah, thanks for the invite, and good night, guys.
Good night. Good night.
Good night.
Thank you, sir. I think we can move. We can move on to the next thing, and then we take the questions last regarding the first case presentation. Harish.
Yeah, I think we'll finish this talk. I think Sabique is ready with it.
Yeah.
He's got to be a very interesting case also. So Sabique, go ahead and get your interesting case done. Then probably we'll take questions later.
Good evening all. I'm Dr. Sabique, consultant orthopedic surgeon, Railway Hospital, Palakkad. Can you see my screen, sir?
Yeah.
Yeah, it's clear.
I'm Dr. Sabique M P, and first of all, I'm thanks to AASK for this opportunity. Today I'm presenting a case of a recurrent posterior dislocation shoulder regarding arthroscopic posterior labral repair with modified Mclaughlin procedure. The surgery was done by Dr. Abdullah Khalil. He is consultant orthopedist and arthroscopy and sports medicine surgeon in KIMS Health Hospital, Perinthamana. Our patient was a 21-year-old male patient. He had a history of fall from height on his back. Since then, he has pain and difficulty with its right shoulder, mostly in the weightlifting and gym activities. He also gives a recurrent shoulder locking leg sensation, but he does not give a frank dislocation history. And he was an AV build patient. There was no generalized ligament laxity, but the range of movements are full, the strength is full. And we got a positive occurrence test, but we couldn't elicit any significant clunk or pain during jerk test or KIM test. And there was no distal neurovascular deficit. We done the imaging, and but the MRI looks fairly okay. There was no labral lesion or cuff pathology was noted. And do we suspected a posterior labral tear? But the report was inconclusive of that. And we done the CT imaging, and it just shows a defect in the anterior humeral head, probably a reverse hill-sachs lesion. This is an X-ray of the patient. It was fairly okay. There is no much lesion was there. And the MRI also done, and it was also no cuff pathology or no labral pathology was noted in the MRI imaging. And in CT, there is a small defect in the anterior humeral head, probably the reverse hill-sachs lesion. And we are plan to do a diagnostic arthroscopy and proceed with the procedure. And regarding the reverse hill-sachs lesion, it's also known as the McLaughlin's lesion. It's an impaction fracture in the anteromedial aspect of the humeral head. And even though there is so much papers are present on the reverse hill-sachs lesion and the management of the reverse hill-sachs lesion, but there is no consensus regarding the optimal management strategy or which provides the best outcomes. And regarding the treatment protocols, we can do conservative management if the lesion is too much small, or we can do soft tissue prosthetic reverse Remplissage or Modified Mclaughlin, or like we can do subscapular tendon transfers, Mclaughlin's procedure, and lesser tuberous transfers, bone grafting, rotation osteotomies, arthroscopic cartilage elevation procedures. All these procedures are mostly indicated for the smaller lesions less than 40% of size of the humeral head. But there is no consensus what type of procedures to be done and which amount of defect in all, or there is no much evidence was there. And even though if the defect is very large, it's more than 40 to 50%, we may have to go for a arthroplasty procedures. And regarding the Mclaughlin procedure, it was described by H.L. Mclaughlin in 1952, where he done an open procedure where he detached the subscapularis tendon and he twisted into the reverse hill-sachs defect. And later the Hawkins and Nearest modified the procedure. He osteotomized the lesser tuberosity along with the subscapularis tendon and he is transferred into the defect, which gives the better biomechanical stability as well as a better healing potential. And since then, there is a several modification of this Mclaughlin procedure and arthroscopic approach were described. And regarding reverse Remplissage is a modification of this Mclaughlin procedure where we have done a suture anchor based distal tenodes of subscapularis tendon into the defect. And it is more suitable to a small defect, less than 20% of the size, as well as less than 10 mm of depth of the lesion. And regarding the this is a diagrammatic representation what we are doing in reverse Remplissage. We are inserting the angles into the lesion, and we are shuttling the sutures through the subscapularis tendon, and we are doing the suturing the subscapularis tendon into the defect and giving a exterior in the defect. This is what we are doing in the reverse Remplissage procedure or modified Mclaughlin procedure. And in our case, we are done a diagnostic arthroscopy in a lateral decubitus position with 3 standard portals, posterior and superior and inferior portal. We are done. We could see a posterior labral tear with a reverse hill-sachs lesion, with a small lesion. With the cuff was normal. There is the anterior labrum as well as the biceps anchor was intact. This is the intraop images, which showing a normal anterior labrum with a normal inferior glenohumeral ligament and the normal biceps anchor. And the posterior labrum was torn, and mostly the superior aspect. And there was a reverse hill-sachs lesion, which is small but is significant. And there is this is a post procedure. We have repaired the posterior labrum as well as we have done a reverse Remplissage procedure. We have tenodosed the subscapularis tendon into the defect. And here we are performing a video how to perform an arthroscopic posterior labral repair with modified Mclaughlin procedure or reverse Remplissage in a simpler and reproducible way using a 3 standard portals, posterior and superior and inferior portal in a lateral decubitus position. Here's a video. We are viewing to the anterior superior portal and walking through the anterior posterior portal, and we are preparing the posterior labrum. With we are elevating the labrum for the repair as well as and we are putting in the first suture anchor. We are used all suture single load angles and taking the suture through shuttle suture through the labrum. We are tying the knots and thus repairing the labrum. And then we are going to the second suture anchor, but we are taking the sutures through the labrum, but we didn't finish the procedure, and we are going to focus into the reverse Remplissage after taking the sutures. And we are debrided the reverse hill-sachs lesion and prepared the reverse hill-sachs for the reverse Remplissage procedure and debrided and kept it there. And after that, we are focused into the rotator interval. We are debriding the rotator interval as well as the anterior part of the subscapularis tendon. So we are getting a working space anterior to the subscapular tendon. Our aim is to introduce this subscapular tendon into the reverse hill-sachs lesion. So we are creating a working space in front of the subscapularis. We are clearing rotator interval as well as the anterior part of subscapular tendon. We should be very cautious about the injury into the axillary nerve inferior to the subscapular tendon. And then we are inserted a suture anchor into the we are inserted a suture anchor into the reverse hill-sachs lesion, and we are using a double-loaded 5 mm anchors, and we are taking the sutures, shuttle the sutures through the subscapular tendon, and all the 4 sutures, and we are taking inferiorly and superior manner. We are taking a parachute fashion. All the 4 sutures are taken through the subscapular tendon by a bird beak in an inferior to superior manner, and all sutures are shuttled. We are shuttling the sutures using a bird beak. Most of the tendinous part of the subscapular tendon, superior part of the subscapular tendon, we are doing this. Since the lesion is small, we used a single anchor. We are viewing to the anterior superior portal and working to the anterior inferior portal. After taking the sutures, we are completed the posterior labral repair. Then we are gone again into the reverse Remplissage procedure, where we are tying the sutures over the subscapular tendon, and we are tying the sutures over the subscapular tendon. Thus, we are closing the defect and introducing the subscapular tendon into the defect. As you can see, there is a tightening, and we are tightening the mattress manner, and the suture is tightening, and the defect is closing, and we are tightening sutures, and the defect is closed. We can see we are tightening from the inferior to superior manner, and you can see the sutures we are tightened, and the defect is closed. In the final image, we are completed the posterior labral repair along with the reverse Remplissage procedure. The defect is exteriorized, and stabilize the shoulder. And postoperatively, we immobilize the patient in an abduction neutral rotation, and for 3 to 4 weeks, we started pendulum exercise as well as wrist, elbow, and RMs. And we have done controlled passive RM for the 4 to 6 weeks, and then active RMs are started, and according to the patient, this one. And then we can then return the patient into sports by 6 months if he's okay. And about the outcome, even though there is too much procedures are described, but there is no much data regarding the outcome of the procedures, because maybe the lesser number of patients. But most of the literature gives a favorable outcome with full regaining of range of motion, even the internotation, as well as the patients were pain-free. In this particular case, we have done 3 weeks back, but we don't have much data to show you. But we have 3 follow-up cases in the past 5 years, and all with a good outcome, which is pain-free and full ROM. And this is my references regarding these procedures. And thank you all.
Thank you, sir. Doctor, what's the size of the defect that you require to always? Do you always do a reverse hill-sachs in posterior dislocation, or just a posterior labral tear and then probably do it? When what is your indication on that particular point? I mean, you have a size of the defect that is required to be addressed?
Actually, there is no consistency, because if it is small, we can go for a reverse Remplissage like procedure. But if the lesion is bigger, we may have to go for a osteotomy or a bone grafting, or even bigger. But only the literature shows if the bigger, more than 40 to 50%, we have to go for arthroplasty. But less than that, too many procedures were described. Mostly lesser tuberous transfers and osteotomies and bone graftings were there. But which size and from where everything is not, there is no consensus at all. I can see any literature for the consensus about which lesion to be, which procedure to be chosen for this manner.
Sabique, what were your symptoms of this patient?
The patient was mostly having symptoms of He's having a pain and feeling of locking and type of sensation. He has most of a pain and discomfort while we are doing a gym activities. He also gives a history of
What
small
activity?
injury during
Because
the
this is a
pushing of
very
like.
small lesion.
Yes, sir.
Very small lesion, and
Yes,
their
sir.
tear was actually because of your posterior labral tear was
Yes, sir.
something like, it was not a tear, it was actually degeneration coming in the posterior labrum. So
Yes, sir.
usually it comes with, overhead activities. So whether that reverse hill-sachs was significant or not was the question. So what was
But the
exactly
patient
the
has
symptom? Because this is
symptoms for past
usually,
1.5 years.
not, not an usual presentation. And, even the arthroscopic picture of your tear was showing, it shows that a repeated some kind of an injury. It was not like a tear. It was something like a degeneration happening there.
Okay.
Yeah, that's the reason I
It is
asked basically. Do you have any size of defect for the reverse hill-sachs? Because it's just or do you almost regularly do it for all posterior dislocations?
No, sir. Actually, it's the patient has yes, repeatedly is having a symptoms for the past 1.5 years. He is mostly
what
doing
symptom?
gym
What
activities
was
and
the
all. He's
symptom?
having a pain and difficulty. Also gives a locking type of sensation repeatedly. So that's why we are actually we are planning this procedure only for that recurrent symptoms. We planned therapies previously, but the patient have recurrent symptoms. So we planned a diagnostic arthroscopy and procedure. Then after the diagnostic arthroscopy, and only we are proceed with the repair and all things.
SIBIN, your take on it?
No, I think that it's a too, as you all mentioned, the size of the lesion, the hill-sachs, reverse hill-sachs is too small for. Is there a stiffness? I suspect for that lesion, if you repair anterior and posterior, my likely to be getting stiff, isn't it? And most likely the pain would have been due to either only the lesion, the posterior labral tear only. Just repairing the posterior labral tear, in spite after good physio, if it is not improving, repairing alone would have been better. It's my opinion. And the symptoms are only pain. There is no other further dislocation. I think Abdullah is there. I can highlight on that.
Yeah. See, John sir and Simin sir, it was literally speaking, it was locking sensation, especially when he was doing any overhead abduction activity. This is sporty guy, 21-year-old guy. And he was also having a locking sensation when he was going for gym. Okay, so he was wandering around with many doctors and he was like, the MRI was inconclusive. So a locking sensation, which is which we thought about doing this Remplissage procedure, reverse Remplissage procedure. So it was a modified Mclaughlin procedure because if you do a posterior labral repair on, posteriorly it is an inherent instability. If it is once happens, it's again it will happen because he has fallen from a 6 or 8 feet height, which caused his first dislocation. He doesn't know what dislocation is, and he was like he was telling he's locking, it's getting locked, it's getting locked. If it is getting locked, doing this thing posterior labral repair alone will not work out. You have to do something on it. I know that there can be a constraint, but usually I have done 2 to 3 cases in this. Usually, if it is very small lesion, if we do this thing, they have a constraint and they'll feel very, very stiff on it. But this is not that small. This is an apt case for doing an Mclaughlin procedure. That is what I think so. If it was a little bit more big, then I will not be doing. And if it is a little more small, I will not be doing it. So, sir, I think it's an ideal apt case because there's no concern how to go about it. If it happens again, then there is no other go except for the posterior bone bulk surgeries.
Elin, one thing is that you are telling, he has got abduction and external rotation problem. But if you have
it's
a
not
reverse
abduction.
hill-sachs,
He's going to gym and he's taking this thing, heavy weights.
So
he's a 21-year-old.
Heavy weights, what you do is that you are lifting the heavy weight. That is, his arm will be in neutral or external rotation. His arm will not be in internal rotation. So a reverse hill-sachs, if it is having a problem,
John
will be
sir,
more in the internal rotation.
I can understand your concern, but the thing is that he is complaining about it and there is no other lesion for his shoulder.
Khalid, my only
maybe posterior labral tear will be getting involved in this your problem. That's what I felt.
Yeah, I mean, I
I
thought
don't know. I don't know. I've never encountered in my practice this anyway. So it's anyway very rare case.
Yeah, and I
Because
was
see,
I
the
wasn't-
thing is like this lesion is seen only if we have taken an CT with high suspicion.
Hmm.
Khalil, how is the range of how long does it take to regain his movements?
Usually it's about almost like 3 months. It's like I told you, it's the third case, but usually it case comes about like in full movements in 3 months to 3 months. But he'll have a little bit of symptoms about till 6 months, but then it's okay. Like
When
some
do you
pain and
start his
stiffness.
external rotation?
External rotation will come faster, but internal rotation I will not allow them to do.
And
till some time.
You feel any kind of weakness in the subscap?
No. Nothing.
Okay, anyway,
Because like when we normally do a cuff repair, we start the rotation only at 3 months. So that's what I asked. What's your protocol on?
No, it's after 6 weeks we start PROM. Then after 2 months, then we start strengthening
So
exercises. Then
you
gradually
start your
release it.
rotation movements also at 6 weeks.
PROM like passive. Yeah.
Passive movements I mean, whether I'm talking that's a abduction and forward flexion and abduction you start. When do you start your rotational movements?
See,
we generally that's why I do start my rotation movements only at 3 months. That's why I asked it.
Johnson, that for a rotator cuff tear. Here the rotator cuff is intact.
But you're tightening your subscap, no? There's tightening your subscap, so it's like a subscap repair there.
But
that's what I
it's a chakrin, just like you do a normal Remplissage, you don't. It's a chakrin, anterior chakrin, to prevent posterior dislocation.
Yeah, that's true. Here it's not a real cuff tear, right?
Yeah.
Anyway, very rare case. I have never seen.
My only thing about this was Khalil was only thing the locking thing which you mentioned, and then
no, he's strictly having locking.
No, I agree. But then will that reverse hill-sachs prevent that? I mean, or be a good solution for the locking is my question. How do you judge that?
That is why there's no concerns about this surgery.
The
there's
locking
no concerns about this procedure.
No. Yeah, I understand. The locking symptom, you mean that it is subluxating posteriorly. That is
it is subluxating posteriorly. That's what I feel. We'll see. Because
Did
2
you
to
get
3
that?
cases
Did you get that on table?
Yeah. On table, is it subluxating posteriorly under anesthesia, under sleep?
No, I have not checked it.
Because your Kim's test and all those things are negative, as you told, in clinical findings.
Yeah.
But, anyway, that's it.
Next time I'll try. I think that's one thing which I have to try looking for it is a posterior subluxation and see.
Yeah, I mean, probably if it's engaging posteriorly, then probably you need to do. It makes sense.
This will make a sense, yeah. but that's the longest series, biggest series, 3 cases, 4 cases. Nobody has ever told about it.
Anyway, well done. I mean, good. He has done it very nicely. So he has shown the video. Well done. We'll go to the other case and we'll.
Thank you.
You're already running late.
Yes.
Any question for the first case? Yeah.
Proximal humerus fractures. I guess the speaker Thomas. Yeah.
It's a very. Yeah, Thomas, are you on? Yeah. So I rarely find, means this is a very common condition, fracture dislocation of the GT with the shoulder. But you rarely see this recurrent or instability after that. Means Johnson, how many any case? This is the only case.
This is the only case I have seen in my 25 years of orthopedic.
I never seen such a patient complaint because they usually become little stiffer compared to the routine.
I didn't want to take any risk. He's an alcoholic. He's a politician, and so I did open lethargy. No confusion. So I didn't want to take any risk. It's very irritating guy.
Arthroscopic surgery, is it a viable option?
It was around 6 weeks only, so we didn't want to do an arthroscopic. We generally now do arthroscopic bone block procedures, but there was already an open surgery being done. So and I want it to be little bit stiff. If he dislocates again, he will give case against me. So I don't want to take any risk. The politician, when I asked him what is your job, I told him I don't do any work. My job is a politician. So I think better to keep away from these kind of people.
Yeah.
So how frequently anybody has seen this kind of issue? Or my question was, should we take a CT or an MRI in all these proximal humerus fractures, which we generally don't do?
In proximal humerus fractures, John, I take CTs for all my patients.
No, for such case, fracture dislocations.
Fracture dislocations, yeah, okay.
Proximal humerus, everybody. If you are planning fixation, the CT is basic investigation.
On fracture dislocation, like this case, no. We do sometimes MRI when we plan for a fixation of a GT to rule out whether there is any pasta associated with that. But whether we can do arthroscopic, but such a large chunk, we generally don't do.
But the literature says in the much classification there is one avulsion. One is avulsion. The other is with whether when the GT hits on the glenoid and it gets fractured, as in this dislocation. But there is always an element of comminution. If the shoulder is landing on the floor, there is always an element of comminution which we miss usually in the X-ray. So there are case reports where when we put the Philos plate and we take care of the cuff also in the Philos plate, but still there can be redisplacement because of the cuff. The tear can pass through the comminutions and the fracture fragments can displace. So better to take a CT in all the fracture dislocation because the comminution part we cannot assess in the X-ray. And if you are going for a plating in a comminuted GT, there is chance for increasing the fracture the cuff because the cuff pull will again aggravate the situation. And there is redisplacement case reports, a lot of. And we had one case where we had to the plating was done, and the patient later came out with pseudoparalysis, and there was a redisplacement of the fragment from the GT. It was a big chunk. For us, it was a straight case of Philos plating. But the chunk, a small piece of this chunk again came out. So it was a comminuted part. So the screw went through the comminuted fracture line, the screw of the Philos plate. So it redisplaced. So better to take and don't take any risk. And if there is comminution, it is better to avoid a plate and go for a suture bridge construct rather than a plating because it will not affect this thing, just the cuff. It basically turns into a cuff surgery. Basically a cuff surgery, like a double row cuff repair. Did you assess the glenoid bone loss, Thomas?
No,
we didn't do.
So I think in such fracture dislocation cases, the glenoid may not be the culprit. It may be the hill-sachs actually, because the head is going out and it is hitting on the glenoid. There is a big hill-sachs possibility. Even if we reduce, there is some bone loss happening at the hill-sachs area. So that might be engaging. So it might not be the glenoid part. It may be the hill-sachs part which is giving more chance for a redislocation.
Yes, when there is a force dissipation happening and you have the greater tuberosity gone, very unlikely that you will have a fracture, on the hill-sachs further coming in. Because that is a single episode of fracture, force coming in. So once you have a GT going on, it will not go in and produce the head damage. Otherwise, it would have been coming along with that. And whenever we are fixing, when you are doing an open reduction of any fracture, you do an open book which is closed. So you are seeing all the fragments there. So when we take the GT out, we suture it, we see the head, then only it is not that we go blindly and fix it. We see it, we take the GT out because usually the GT will be displaced posteriorly. So you put the suture bite, you suture bite, you open it, then you put it back, then put the plate and then you suture it to the plate also. So you are seeing entire thing. So very unlikely. I have never seen, the head getting involved. But here I feel another thing is that, when you have a fracture, like a dislocation in elderly, when you talk about cuff, when you have an elderly patient dislocating first time, more than 55 years, mostly they will have a cuff tear. So you have to just repair the cuff. You don't have to even repair the labrum. That's what
Yes,
they
yes.
until if
That was my next question,
it's a
whether the
bony.
cuff was involved.
Yeah, if it is
Because
a
the redislocation always cuff is.
bony bungut, you have to repair. Otherwise, if it is just a labral tear, you just have to repair the cuff.
So yeah, three possibilities then. One redislocation after this, it's one maybe the bony bungut we missing.
I didn't find any bony bungut when we opened for this one what
Only
open leather.
possibility to prevent a proper MRI.
Yeah.
So it was a good call to go for open leather. So as you said, when we go for anterior deltopectoral approach, how far can you see the posterior part? Because we take bites in the cuff and place it on the plate and tie. We cannot see the posterior part because the hill-sachs is in the posterior part of the head, right? In anterior dislocations. So we are not usually exposed to the posterior part.
But the head,
that's my argument.
The shaft is
Maybe
intact. So you rotate your head, it will come. Rotate your head, you can see where it is. If there is a head and the shaft is separate, that's a 3-part fracture, you will not see. When there is a fracture dislocation of the GT, that's not a 3-part fracture. It is usually a 2-part fracture. You can
maybe there's a blunt something which causes a blunting of the head. Maybe the fracture.
You can nicely see when you take. This is a large fragment, and when you take it out with your stitch, you can when you lift it, you can nicely see the head moving around.
So, what is your argument? How it redislocated? Bony loss, glenoid bony loss?
I don't know. Maybe
cuff tear. Yeah, maybe.
I have no idea. Maybe.
So, John sir, one important thing take home that you can in a relatively elderly patient when such a fracture happens, it's better. I think we can CT scan. Two things, two advantages. You can rule out undisplaced surgical neck fracture is there. Sometimes it may be associated. You try reduction, it gets displaced, then the blame is on us. And secondly, it may tell you that whether there is any bony bungut or not. Understand? If there is a bony bungut, you can keep in mind that it may need a fixation later on if it is displaced.
Perfect. And the communication
is better. Just like Harish.
And lot of papers saying comminution of the GT. That is also undisplaced.
CT will give you the correct picture.
Yeah, CT is always good.
One simple question: if suppose you are treating this fracture dislocation non-surgically, how do you immobilize? Is it in normal arm pouch or is it in abduction pillow with extra rotation?
We immobilize normally. We don't do if it is and we put it just on this on a arm pouch, and we take serial X-rays weekly till 1 month, and after that we mobilize the patient. If we consider, we don't.
Conferences, it was told that it's better to immobilize in abduction and exrotation. The chance of posterior displacement gets reduced because of the posterior pull. So
these days you have the arm pouch along with the pillow also.
Same thing.
Just very like cumbersome. Perfect. Very cumbersome, and the complaints of the patient may not be that great to use this abduction external rotation splint. I don't know how many. I have seen earlier, people, my other unit used to use that, and it looks very cumbersome. People holding with the pillow and sitting and walking around.
No, Johnson, I'm not asking the pillow. The commercial one available.
John, there's a commercial one available with a normal.
That's there. That's
the normal arm pouch with a pad in between. So you just need to keep that close to your body. It stays in abduction.
It's abduction and little external that chances that reduces the chances of redisplacement. That's what people say.
Point taken. Okay.
So I think the take home should be for the first case should be that elderly, when you get a fracture dislocation, better to go for CT. Is that CT. Everybody agrees?
Agreed.
Okay. Any more questions?
Can I make a point on the point which Dr. Hayas made about the plate versus suture bridge for greater tuberosity? Because he said the fracture fragment came off from the screw, but then that actually shouldn't happen if you follow the principles. Because in a greater tuberosity fixation or even any plating, the crux is on taking a bite on the tendon, isn't it?
Cuff,
So if you take a bite on the cuff, then it should not come off. The philos has better hold than anything else. But then it's an open surgery. For arthroscopic fixation, you can do a suture bridge, which has the best
fixation. But then when you compare both, I would always watch for the plate. If you can put a plate and take a wire and wire it onto the plate, that holds much better, I think, isn't it?
Yes, sir. This case actually was done from elsewhere, and it came. The patient was having a simple same fracture dislocation with a big chunk of GT. It was plated beautifully, and the index surgeon told he had taken proper bites in the cuff, and it was tied.
But if
the
there are
patient
bites in
came
the
with
cuff,
an
it cannot
X-ray.
come off. Yeah, exactly. That is a mistake of the index surgery.
But I feel what happened is when I opened it again, I feel that there was a cuff and a piece of bone was attached on the cuff, a piece of the GT.
Exactly. So if the
It is
you have
like
to
a GT
disregard the
avulsion.
bone. Yeah, you have to disregard the bone piece and take the cuff onto the plate. That's what you have to do, isn't it? If that was done, it cannot displace. It cannot displace. It's properly done.
Yeah, the cuff was repaired, but the patient came back with a GT avulsion.
Exactly. So
maybe a retrauma.
it is just like a young surgeon doing a TBW of olecranon or a patella, where they look at the image and do. When the bite is not taken through the tendon, it just goes around the metal wire and just comes off.
But the failure was not in the bite.
The point
was intact. On revision, the bite was
probably if it's
intact.
taken through the tendon, probably shouldn't pull out. That's the whole.
Exactly.
That's exactly.
Yeah, but the bite was taken properly, but the screws I think went through the comminuted that area, and because only 3 screws maybe in the top, it can go through
But then screws don't have any role there. Even if you don't put any screws there, it should work.
Suture
If you have
tying is
good fiber wire bites on the tendon.
Attaching it to the plate, the suture attaching to the plate is the most important.
That is the most important.
Basically, it should be cuff surgery. Yeah.
Even I think everybody has got this kind of fractures where the bone fragment get resorbed after some time, but the patient does very well. We have few patients after fixation. If you look at it, after 3 to 6 months, this bone completely get resorbed. Then we will find there is a big hill-sachs kind of a defect, but the patient is pretty happy. There is no issue
because the cuff is healed, isn't it?
Yeah, because the cuff is healed.
Correct.
Yeah, I think.
But the X-ray looks very terrifying. Once you see at 6 months.
Yeah. And older patients are very forgiving, unlike younger ones. They don't dislocate as much.
Yes.
Yeah. Harish. I think we wind up in. There are no more questions.
Okay.
Welcome.
We've had some excellent talks and some great talk by Dr. Ming also. So fantastic evening. I think Wisdom Trail has successfully completed another good series. We've had interesting discussions on it and certain specific points to be taken home regarding fractures as well as the reverse hill-sachs as well as the cuff options. So it's been a great talk. Thanks, John, for the invite as well as SIBIN. And you probably take it from here, and then we hope to have a greater session next time. Yeah.
I think this is the first time. Before we wind up, we should thank the Ortho TV for associating with us, and I think this talk will be available in Ortho TV, and that's a great thing for all of us. So the talk will be available online, not only for the regional people, but whole national it is available. So I take this opportunity to thank the Dr. Ashok Shyam and the whole team of Ortho TV for their association with us.
Perfect.
We will continue this in the next webinar also.
Yeah, great.
Okay, so thank you all once again.
Okay, thanks.
Perfect. Thanks.
Thank you all.
Thank you, everyone. Have a great night. Thank you.
Good night, Good night, Harish.
Good night. Good night.
Bye. Thank you, Ortho TV.
Good night.
Good night.
Recording stopped.